Welcome to the APAP podcast. I am Corinne Young. I'm a nurse practitioner and the president of the Association of Pulmonary Advanced Practice Providers. And today joining me is Kenny Larsen. He is a physician assistant from the Carson Tahoe area in Nevada. We're talking to Kenny today because he runs a very specialized COPD clinic for just seeing COPD patients, managing them, keeping them out of the hospital. And this is becoming a newer phenomenon, at least new to me, and something I thought we should all talk about and learn how to create, look at analytics and how this is run. Kenny has been a physician assistant since 2012. 2012. He got his degree from Eastern Virginia Medical School. He is a member of APAP and on our CPD committee. And also is a member of the American Academy of Physician Associates, Nevada Academy of Physician Associates, and College of Chest Physicians. So we are doing our very first live podcast, recording together. He flew out from Nevada to Denver for our second regional meeting for 2025. And so I thought I would capture him while he was here and get a podcast recorded. So thank you for joining us today.
My pleasure, Corinne. Thank you. And congratulations. These regional conferences are awesome.
I'm pretty excited.
Great work. And exciting things at APAP.
Excellent. All right. So let's dive right in. Now I'm calling it a COPD center. As I've been traveling around, I've been running into these clinics that are run by APPs. A lot of them don't have any physician supervision or engagement. It really is physician driven, where the APPs are managing COPD specific, just that disease state, which of course no disease lives by itself, but they're treating COPD patients, keeping them out of the hospitals, optimizing their COPD, really tuning them up. And I've heard them called all sorts of different things. So what are you calling your clinic?
We call it the Carson Tahoe Health COPD Clinic.
Yeah.
And we do that. We focus on readmission reduction primarily. And then from there, that entails a whole lot of education, access to medications, and just kind of management of the patient.
So how did it first come about?
So back in 2010, there was a small piece of legislation. You may have heard of it, the Affordable Care Act. One of the things within that was the hospital readmission reduction program, and that focused on several diagnoses, which eventually led to including COPD in 2014. But in 2012, CMS began this carrot and stick approach to the management of hospitalized patients. There were penalties for increased percentages of readmissions for certain diagnoses. And there were carrots ingrained in that allowed for adequate outpatient follow through and follow up with these patients. And so that really birthed the transitional care kind of model that we use at Carson Tahoe. And that I think is popping up all over the country.
Excellent. How did it get started? Like, who are the people that were really invested in it? Who really drove it? Also, if you could speak to if this is something that pulmonary APPs out there want to get started on their own, how would they go about getting started?
Yeah, so we started in Carson Tahoe. I got to give all credit to Carmela Downing. She is a cardiology physician assistant, and heart failure was one of those original diagnoses that was included in the hospital readmission reduction program. So she formulated this clinic that allowed for both inpatient access and outpatient access to these patients. And she thought, gosh, this is working so well, we should do it for COPD. And in Northern Nevada, there is a lot of COPD. And so we've kept really busy with this model here. It really is a hybrid inpatient, outpatient opportunity that allows for a continuity of care for patients that I think, we're always trying to get, but it's just really difficult to facilitate those logistics. And so having it combined in one clinic has really kind of streamlined that process and given us control over just that continuity. After a patient leaves the hospital, they have somebody that they've seen in the hospital that is now providing ongoing care.
So tell me about your day. Are you doing both inpatient and outpatient work?
Yeah, so in the morning, around 7:30, 8 o'clock, I'll be inpatient, and I just look at the hospital census, and kind of tease out those patients admitted. We can filter by diagnosis, which is the easiest, but a lot of patients are diagnosed with many things, including acute exacerbation of COPD. So it really kind of takes some time to go through the census and identify those patients. Once identified, I go in and chat with them, introduce myself, introduce them to the clinic, and just let them know when they get discharged, they're going to get a call. And I work with a nurse who kind of tracks those patients. Once they're discharged within 2 days, so we give them a call and say, "Hey, when's a good time for you to come in and see Kenny?" And then we try and get them in within 7 to 14 days of discharge, and that is in line with some of this transitional care. I talked about carrots before, right? This is the carrot. Transitional care billing is a huge incentive to kind of make this program worth it.
So do some of these patients already have pulmonologists, and how does that work if they're already established with a pulmonologist or another pulmonary practice?
Yeah, great question. I think some of them do. I'm surprised at how many patients with COPD diagnosis don't have an established pulmonary specialist. But they do, and that's okay. I think in this clinic, because it is so focused on readmission reduction, um, my experience is that pulmonary groups are happy to have that kind of support, because they want access for these patients. But the reality is, there's a dearth of pulmonary providers, and so they're happy to have the support from the COPD clinic. I'm not employed by them, and I'm not building a practice, which I think they recognize and are grateful to just have that community support.
So you're not necessarily hanging on to the patients after that first visit. Do you ever see them after that first visit outpatient?
Yeah, I think the point is beyond readmission reduction, or it can be beyond readmission reduction. And so you want to make sure the patients are comfortable with the strategy that you have in place to keep them out of the hospital. And so I'll follow up, after I see them initially and we come up with the game plan. I'll follow up with them within 2 to 4 weeks of that first visit and just make sure that we're still on the right track. If we need to make adjustments, we'll make adjustments. But the hospital readmission reduction program is 30 to 60 days that you have to keep that patient from going back into the hospital. And so what I've said is 30 days after discharge, it's my patient. And I just kind of take ownership of that. And then afterwards, if they want support, if they need help, I tell them you have access to this clinic whenever you need it. But I'm not going to be your pulmonary specialist. I'm not going to follow nodules. I'm not going to do lung cancer screening. Now, if it comes up, during their hospitalization, then we notify lung specialists and we can kind of do some of the initial workup. But this is not intended to build a practice. It's really just intended to give patients the tools needed at a critical moment in their recovery to keep them going back into the hospital.
What do you think the biggest thing you run into to optimize these patients to not return to the hospital or to reduce their exacerbations? What's kind of your top items that you tend to think that everybody needs when they come out of the hospital?
Yeah. I mean, I thought it was just access to somebody with a great personality, you know? Um,
All of our patients would be cured if it was just that. I mean, we're a hoot.
that's a good point. No, but I was surprised when we initially started the program. We did a spreadsheet and we tracked things like um, what medications were the patients on and what were they discharged with. And it wasn't long before we recognized that patients discharged on triple therapy had a better chance of not going back into the hospital. And it wasn't close. In fact, we tracked it for maybe 4 to 6 months, and it was just obvious. And so at the risk of, my ego, it isn't access, although that's a big part of it, absolutely, but, if we can get them on the right medication, the right therapy, it really is important at helping reduce that risk of going back into the hospital, and that was, like I say, it was pretty stark when we tracked it.
Yeah, I mean, that's data we've been seeing other places. It's always nice when your data matches,
Right.
you know? Okay, so other than triple therapy, making sure they're optimized to triple, are there other barriers or other things that you see that these patients are more likely to get readmitted? These ones are, these are some fine tuning that I can do before sending them back to their pulmonologist.
Yeah, so my background is in respiratory therapy. I was a respiratory therapist before I went to PA school, and, so I think the skills as a respiratory therapist, breathing mechanics, talking patients through that dyspnea cycle, a lot of those readmissions are them just being scared and not knowing what's going on, and so helping them recognize that, I've said this a lot, but change in structure causes a change in function, and they have to recognize that they have to slow that breathing pattern down to break that dyspnea cycle. That's been really helpful. And then they can kind of talk themselves out of going to the emergency room where they're just going to get admitted. Let's face it, any severe COPD patient, they step in an emergency room, they're going to admit them. And so we try and help them cope with that shortness of breath a little bit easier by box breathing, pursed lip breathing, just those simple respiratory mechanics exercises can go a long way at giving the patient a little bit of time, getting their nebulizer, right? Breaking that dyspnea cycle, and then call the clinic and let us know what's going on. And if we need to see them a little bit sooner than regular follow-up, we can bring them in.
Are you seeing acute exacerbations in your clinics?
Yeah, absolutely. So it's not infrequent that patients have that kind of rebound inflammatory process, and they're still kind of in that exacerbation. And so they're stable enough to go home, but are still pretty sensitive. And so we'll see them back in the clinic, and we may have to extend, things like oral corticosteroids or maybe even macrolide antibiotics. But the goal is whatever it takes
Yeah.
to increase the distance from that discharge to their next admission.
Are you ever seeing those patients back for acute exacerbation, them contacting you versus going to the hospital, let's say, 6 months later? Are you their point of contact or
Yeah, I mean, it kinda goes against the initial kind of philosophy of the clinic, but it's difficult when patients are in trouble and they need access, it's difficult to say, sorry, go to the emergency room or go to urgent care." Because there's a lot of different ideas out there, and the severe COPD or, they need a little bit more intensive care a little bit sooner in that exacerbation. So we'll see them absolutely, and a lot of times it is all right, tell us what you're doing, and if their initial steps are appropriate, then we'll say, all right, no, you're on the right track. Okay, let's maybe give you a little bit of support, with an OCS for a little bit, and it breaks that for them. And like I said, we can do a lot if we just allow that access, I guess.
if you're seeing a patient, they've had multiple exacerbations, is it the role of your clinic to start talking about more aggressive therapies like biologic therapies in these COPD patients now that we have options for biologics?
Yeah, and I think with the information coming out on the ramifications of that hospitalization, right? It is a significant issue for patients. Once they get in the hospital, that starts the clock for a lot of them. And I I would say I'm probably a little bit more, definitely a little bit more progressive than Northern Nevada practice is. But if you think about it, Corinne, that is the best time to identify a patient that is appropriate for type 2 inflammation therapy because they're going into the emergency room. And before they get the steroids, they get the CBC with differential,
We
hopefully.
hope.
Yeah. And then that identifies that for the patient. And I think there's a lot of promising things about the future, and we can get into that. But yeah, absolutely. I think the 10, 15 year ago, hey, let's just tiptoe our way into escalating therapy. That's that's not the way to do it. And I think studies show aggressively treat that and then back away once you get control. I think that's the strategy we employ.
I think it's such an opportune moment for the patient because you have their attention,
Right.
right, after hospitalization, where in community practice, we may not be able to make the time to see them that quickly, still have their attention about the exacerbation. They know they're seeing you because they had an exacerbation, right? And that you're gonna tune them up. So I think it's a great, opportunity for you to really have their whole attention about you went in on these therapies, and to prevent your next one, we're gonna talk about these other therapies, right?
Absolutely. And Tyler Cook, the committee chair, he called it the debrief appointment, right? I mean, you have just been through something. Let's debrief and see what led to that. And that's wisdom, right? That is knowledge gained through experience. And that's the perfect time to really kind of get patients understanding, hey, this is what's going on inside your body. This is why it's doing what it's doing. And this is how you, as the patient, can manage that a little bit more effectively.
I could see such benefit in it because, again, from community practice, sometimes, when you have multiple hospital systems in the area, you don't know where your patient's going to end up. You don't even know that they were in the hospital. Sometimes you're
Right.
not even consulted. In our case, sometimes the hospitalists are managing them
Right.
for their exacerbation. So they're coming to see me for their regular follow-up, and they're like, "Oh, by the way, I was in the
All
hospital."
right.
So I'm not prepared for a hospital follow-up necessarily to have that debriefing,
Yeah.
per se. So I could see something like this being so beneficial on so many levels, especially if they saw you, then they're coming to me optimized, what's been changed, and now I'm managing that.
Right.
I can definitely see some great, measures there. You had mentioned spreadsheets.
Yeah.
I'm a nerd for numbers. I love me a good spreadsheet, okay? My husband will tell you nothing makes me more excited than an Excel spreadsheet. So tell me about your analytics. What have you guys been able to measure by intervening with these patients in this way?
Well, I mean, I hate spreadsheets, so we are opposites as far as that goes. And if I didn't see a spreadsheet again in my life, it's mainly my own insecurities, Corinne, I must be honest. But what we identified before we started the clinic, Carson Tahoe had a readmission percentage in the mid 20s, which, that did qualify them. If that was persistent, that would have qualified them for one of those sticks that Medicare has, and they would have had reduced reimbursement for their overall hospitalization. So, we're talking about a pretty good chunk of change for a health system. And that kind of was the catalyst to starting the clinic in the first place. But after we got things up and going, it didn't take long before like I said, we recognized really potent, effective ways to keep patients out of the hospital. And it was just access to healthcare, right? Access to appropriate therapies, access to education, access to interventions if they needed it. And so we're running now in the low teens as far as our readmission rating. And we've been there for the last, I don't know, 5, 6 years. And
What's the nationwide average? Do you know?
I think it's probably mid-teens. I believe it. I asked ChatGPT this before I came in, and I think it was in the between 15 and 20%.
Is the
Is the
average for
average. Yeah, and so the standard is less than 15%, right? I mean, that's what Medicare wants you to get to. If you're less than 20, then I think you don't qualify for the reduced reimbursement. But they want you obviously as low as possible. And so we've been pretty steady in the low teens as far as our readmission, and that is in probably the top 10 percentile in the nation. So it's not a difficult thing to do, but it does take, you know, something like that, something different, to get there.
Okay. I could definitely see APPs that maybe work for a hospital
Mhm.
system, right? And maybe even the pulmonologists are employed by the hospital system. This would be a great place for an APP to raise their hand and
Right.
say,
Yeah,
we could start this clinic.
absolutely, because it will benefit the health system. It will benefit the patient. It will benefit the group, the practice. It's a win-win all the way around. And so, and payers are on board with it too. So, it would be very easy for someone within a health system that is already credentialed to be in the hospital anyway, to just gain that access and say, "Look, this is what I wanna do." And if you can marry that inpatient, outpatient, and just maintain that continuity, that's the key. And for me, I hate making phone calls. I really just despise it. And so I have a
Spreadsheets and phone calls.
spreadsheet, pretty much anything in an office. No. Um, but I work with a great nurse and, we've employed respiratory therapists in that position. We've employed, medical assistants, even. The nursing has opened up, prescribing opportunities so they can send scripts for me and that allows for more timely intervention. But, yeah, she handles all the follow-ups, she handles all the questions that come in, like, "Hey, what's happening? What should I do?" And then if she thinks, "Yeah, you should come back in and talk to Kenny," she'll schedule it and make that arrangement, so it's awesome.
RNs are so important. We got our first RNs in the practice a couple years ago, and they navigate a lot of our very sickly patients, high acuity patients. And there's this knowledge gap between medical assistants and nurse practitioners and PAs. And unfortunately, it lands on the APP shoulders, everything. And that doesn't need to come to the APP, right? And so having those nurses there, they filter so much
Absolutely.
through that doesn't end up on your plate. What's difficult is they're often non-revenue generating, which we've recently learned how to make them a little revenue generating with continued care management,
Right.
CCM, and things like that have been a way for us to recoup some more costs there. And then just work quality of life. It's just worth it. It's just so worth it to have an RN in your practice, especially if you're going to navigate any disease.
Absolutely, and when you consider all the money saved from penalties, when you consider, cost to the health system with readmissions, it really does make sense, and that transitional care billing it's pretty legit,
Yeah.
and so it kinda pays for itself to facilitate that, and I know it's always a struggle between administrators and providers, what kind of clinical resources are needed, but I definitely think having an RN in that position has been just
So
fantastic.
at least
It's
one
great,
APP and one RN.
right? And we do have a medical assistant that works with us, and she rooms the patients, it does chart prep and all of that. But if you wanted a lean clinic, an APP and an RN could bust that out, and it would be efficient and effective for sure.
That is so interesting. As I've been traveling around, spreading the good news of APAP,
Yeah.
trying to find as many pulmonary APPs as possible, I have run into several of these COPD clinics. Some of them only are outpatient, some are doing inpatient and outpatient like you are. Is there any resource for you guys as far as learning from each other, or is this another committee APAP's going to have to make?
I don't know. It may be a
Use?
subcommittee, within that COPD committee, and I think that's something to look into. I think, networking is gonna be so important because there will be information that other APPs will gain from their experience that's gonna be really valuable for me. And so I think having some resource to network is gonna be important. I think APAP really is kind of already set up to help us with that. So, I think that would be useful. I think, beyond that, you just find out, all right, what do the studies say, right? What's going to be most helpful? We have resources that I think can be helpful for patients, educational wise, but I really think it is person to person, provider to patient. This is what's going on. This is how we're going to manage it. And there's something that changes in that patient. It goes from an obscure kind of voodoo kind of illness that just threw them into the hospital to, okay, this is my body just doing what it was designed to do. I need to know how to cope with that a little bit better. Right.
And understanding it's not just bronchitis.
Right.
right? It's
Yeah,
not, oh, I
exactly.
just got
Yeah,
whatever from whoever. And yeah, that it is a different process and outcomes. Unfortunately, like you said, a hospitalization related to their COPD changes their trajectory.
right,
And a lot of data out there about mortality in a year and at 5 years,
right.
with just one hospitalization for COPD exacerbation. I think 1 year that was a little about up to 20% of patients,
Yeah,
are dead in the first
right.
year after one exacerbation that requires hospitalization. And then at 5 years, it's
I think it's 50%,
about
right? Yeah,
50%. Yeah, it's pretty high.
yeah,
So, if you love your patients, half of them are going to be gone if we don't do something for them, right? So even if you don't love them,
yeah,
about 50, we want to do what we can to change that trajectory for them. And I think
right.
this is a big piece. Do you know if there's any data out there on mortality outcomes with interventions like this?
No, there's some data out there that does kind of suggest that mortality is increased with readmission reduction programs. Um, and again, it's not strong data. And I don't know what that means, to be honest with you. I tell my patients I'm less concerned about quantity of life and more concerned about quality of life. And so if the patient is living better but dying younger, yeah, I can see the value of that, and I understand the other spectrum as well. Um, but I think the data is new, and I think we really have to kind of break that down and tease out exactly why that is. It may be more oral corticosteroid use. And I know that my threshold to provide that to a patient is a little bit lower because my goal is keep them out of the hospital. And so that's the value of emerging therapies too, is that, yeah, we know it's the devil that we know, right? But if there are alternatives, we should be looking for those alternatives. And that may skew that finding. But again, it was very preliminary. It was very kind of obscure, and I don't know how valid that's going to be as time goes on.
Yeah, it's hard because of bias in patient selection because you're seeing these very sick
Right.
patients, right? And
Absolutely.
and patients who are having exacerbations and, not necessarily randomized,
Right. Yeah.
data. So it's probably claims-based data I'm assuming they're looking at. So
Yeah. And it doesn't take into account severity. It doesn't take into account. I don't even think it controlled for age. And so it's kind of one of those. It's a hard thing to kind of figure out mortality data, but gosh, if we can optimize quality of life in the moment, that's the other value of programs like these. And I think it's very fulfilling for me as a provider to provide that hope to patients to help them recognize, all right, we can manage this in a way that's meaningful.
if you were to give advice to someone who is thinking about getting this started, what should they start looking at? Who should they start pulling into conversations about it?
Yeah, gosh, go to the CEO and the CMO and just introduce this to them. If it is without buy-in from somebody like that, it's going to be really, really hard. Even if the physicians in your group are on board with it, they are limited in their capacity to really kind of authorize certain functions within the health system. And so, if you can get your chief medical officer, they're probably the ones that are going to be on board with this. My chief medical officer also happens to be my attending physician. So in Nevada, we're still, we have collaborative agreements, and so um, fortunately for me, I have the ear of the chief medical officer and can just chat with him about what needs to happen. And he's been fantastic with that. But if you can get buy-in from administrators, that's going to be the key. And the numbers are easy to persuade any bean counter as to the validity of it. And to my knowledge, this clinic has not been a draw on the health system. It has been a revenue generator. Plus, it's helped them avoid, penalties. So, just make your administrators aware of it first and foremost. Hey, there's these programs out there, and we could be at risk of penalization from Centers of Medicare Services. I'd like to help us avoid those penalties with a COPD hospital readmission reduction program. And then that should get them thinking. And then when you look into transitional care management billing and things like that, the numbers will add up, and it does kind of make sense. But yeah, get that buy-in.
And that transitional care billing, it's competitive because it's the first person to see them, right?
Right.
If I understand it correctly?
Well,
So,
yeah, yeah,
if
can
they
be,
see the
yeah,
primary care before they see pulmonary, we don't bill for it, and we don't know who they've seen, what's happened
right,
oftentimes in a community setting, and so we just don't bill for it, and so we're leaving, I know, money on the table, in that case, but yeah, if you know you're seeing that patient just a week or 2 or
right,
so after admission, you're likely the first person to see them, so and it does pay very well.
yeah.
Yeah,
Yeah, so I think, yeah, for a group standpoint, having that knowledge and access to it, I think the key for our clinic is that we do have a registered nurse tracking those discharges and calling the patients within those 2 days. And all of that is just written into transitional care management anyway. And so you just kind of follow that and it automatically qualifies the patient for that billing. And it's that continuity that we're looking for to, kind of maintain, hey, I saw you in the hospital. Um, reaching out to you now. What questions do you have? And what can we get you into the clinic?
excellent. Do you get much pushback from patients following up outpatient?
Yeah. I mean, some patients just, they're not interested, but I think the first 2 years we were 50%. Some would come to the clinic, some would not. That has improved with me. We have a notebook, that I leave in the patient room, and, it says COPD on the front of it. It's got my contact information on the front page, and then it has some educational materials, right? What COPD is, what medications are used to treat it. Um, and it is something that we're encouraging discharge planners to make sure the patient has, before they leave the hospital. That has helped because, again, continuity, they recognize, oh, that's the guy that came in and said he was going to follow up with me and keep me from coming back into the hospital. I better give him a call, right? Or I better take that call or take that appointment.
And so metrics now look better as far as follow-up?
Yeah, yeah, I think we're 70, 45. It kind of fluctuates, depending on how warm it is outside or if there's a holiday coming up. But yeah, it's better. It is, and ideally, we get 100% of patients that leave the hospital. But I think the best we've done is 80, 85%.
Oh, that's really good. That's
Yeah,
really good.
yeah,
Okay. Well, I would say, to anybody out there that's already has this COPD clinic, feel free to contact APAP, and we
yeah,
are happy to put you guys all together.
yeah.
But any other advice that you would give, or little pearls of wisdom that you've learned working in this type of setting?
Um, I think I don't know. I think advice wise, it's worth it. You know what I mean? When I initially started this clinic, it can get kind of frustrating getting people in line with what you're trying to do. But be persistent. It's worth it. It's supported by data, and it's a net revenue generator. So you have so many reasons why this makes sense. If you just stick with it, people will come around. And then I would say, don't discount the exacerbation, right? Those little exacerbations are going to progress and they'll become bigger and bigger. And when you see them in the hospital, that starts the clock, like I say. And we want to extend that quality of life as long as possible. Reducing the frequency of exacerbations is a meaningful way to optimize the health of patients. And it is very fulfilling when they come back and they say, yeah, I think I got this. And I'll have patients that want to come back. They're like, I just want to check in, and we'll allow for it because it helps my ego, right? And they come in and they say, "Yeah, I've stayed out of the hospital." And I say, "Gosh, man, aren't we great?" And they say, "Yeah, we are great." And you put it on them. I think patients want to manage themselves. I think that's the other thing that was inspiring to me is that once patients kind of get it, they're happy to self kind of manage. And when they run into problems, they can reach out and get answers to those questions. But gosh, giving them the tools to manage that is very fulfilling. And you take success in their success, which is great.
Oh, yeah. The scariest thing is the unknown, right? That's why
Right.
scary movies, you don't know what's around the corner or in the basement or whatever it is, right? It's the fear of the unknown. And the same thing goes for these disease states is that they don't know what's next or what's going to happen. So giving them those tools, giving them a plan, we have these asthma action plans. I give my patients a COPD action plan. You have these symptoms, you take this, you call me for that, you go to
Right.
the ER for this. They know what to do. They know there's a plan for them
Right.
and steps to take to help their symptoms. That if this doesn't work, my plan B is this for you. My plan
Right.
C is that for you. They love that,
Yep.
and like you said, they do like to. It gives them a sense of control that they can do something, participate in their disease in that way. And of course, that's not every patient, right? With patients who don't want to, and that's okay too. But for the ones that do, I've seen firsthand that huge shift in their confidence and their anxiety is less, and just the more they understand. So I think that's a big part of what you're doing in that clinic, and you don't get bored seeing COPD every day.
You think you would. And, yeah, sometimes it's like, "Oh, this is kind of a drag," but it usually is the anticipation to go to work, but once you start seeing patients, it's like, "Oh, yeah, this is legit. This
You know,
is
I would just kill
this is
for
cool," you
ILD
know?
right now or something, right?
I don't think I've ever said that, but no. No, it is, you're just like, "Okay, yeah, that's what I do," and people ask me, "Well, what is it that you do?" And I say, "Well, I tell people to quit smoking and lose weight all day." And they're like, "No, really, what do you do?" And I said, "No, I keep people out of the hospital, and I improve quality of life, and, it is meaningful, and it's meaningful to the patients, to their families, and to other providers." I mean, I think the health system as a whole really sees the value in clinics like these, and, providers are just grateful, and patients love it. They love it, and they'll go back and see their primary doctor and say, "That provider is awesome." And so it really is, a fulfilling way to practice medicine. It is I do feel like the only thing I do is talk about airway resistance and breathing mechanics, um, but it is fulfilling when it comes down to the patient. So, again, it's worth it.
Well, and great job security as well. I mean,
Sure.
our COPD rates aren't necessarily declining,
Yeah,
and there are so many new therapies for COPD that are coming where you could be the first
right.
person they get to talk to about that, right?
Absolutely.
Yeah.
And you will be a leader in the health system or in the group, right? Because it is advancing pretty rapidly, and, I get a little anxiety when I talk about these biologics to people that are completely naive providers because, man, it's only gonna get more complex,
Mm.
and, being having wrapping your head around this theory of treating patients and this type of information, I think, yeah, is gonna be important for providers to stay up and be kind of the leaders in this field. And so that has been encouraging for me too, because I do have information that people don't know, and I'm able to, kinda educate them.
Yeah, I think it should be called the COPD optimization clinic.
I like
I've
it.
decided that's what it should be
I
called now.
like it.
Cool.
We're gonna have to get the printers,
Change all your cards.
throw those books away. We're gonna reprint them. No, I like it.
Yeah. Well, Kenny, thank you so much. I appreciate you staying late and recording this with me, for coming all the way out to Denver to our second regional, for participating in the CPAP committee for APAP. You have helped us bring a lot of information to our members, being faculty, all of that. So, really appreciate you so much.
Yeah, absolutely. It's my pleasure. Thank you. And this was great. I'm excited about what APAP is doing and just happy to be a part of it.
We are too. All right. Well, thank you guys for joining, and we will talk to you on the next podcast. Don't forget to like and subscribe. Please subscribe on YouTube. That is one of our ways that we can help bring you free content and free CMEs, like at our regional meetings. Hopefully, you'll be able to join us for a regional in 2026. You can always go to palmapplive.com to look at our regional and our national conference, and then our website is palmapp.com. So, thank you again. Talk to you guys next time.